I had an abdominal aorta ultrasound done where they
Hmm.
found a lot of I can't say it, but atherosclerosis in
Yep.
the aorta.
Sure.
But I
Hmm.
also have I have leg pain. However, it doesn't hurt when I walk. My legs don't swell. I can pretty much walk, as far as I want, but when I lay down at night to go to sleep,
Hmm.
it, or if I'm in a sitting position driving, it feels like someone is stabbing me literally all over my legs. It hurts terribly. And it happens, I'll lay in bed, I'll be in bed for like an hour and it just constant stabbing, shooting pains all over my legs. And then when I
Hmm.
stand up to go get Tylenol or whatever, the pain does go away. So it seems like it happens when I'm laying down or when I'm sitting. And, I'm kind of worried about that. Plus, I'm worried about the fact that I did have the arterial um, Doppler ultrasound recently done on my legs, but I
Hmm.
don't know how to read the report. So I do know it
Sure.
says there was no occlusion. So apparently that means
Hmm.
no blockages, but then they have all the um, numbers, you know,
Hmm.
and I don't
Yep. The
understand what that
velocities.
means. Yeah, the
Yeah.
velocities, and I don't know how high,
Mhm.
low they're supposed to be. So,
Yeah, and that's okay. That's for us to kind of figure out and take into the clinical picture. Yeah, just because so atherosclerosis is basically just hardening of the arteries. That's what that means. So the fact that the abdominal aortogram that they did or the ultrasound showed that you had atherosclerosis means that there's early processes beginning there of circulation issues. Not to say that you're going to develop those in the future, but the arteries become hardened. Arteries are very elastic. They have to be to accommodate all the blood pressure that the body's circulating through. With all those risk factors I had mentioned before, those arteries become hardened. When they become hardened, that's when the problems start. Because we're trying to get all this blood flow through a very rigid structure at that point. Doesn't necessarily mean you have blockages. Now, uh, this is a perfect example of kind of what I was alluding to before, why it's very, in some cases, it's the diagnosis of PAD, especially in the lower extremities, is delayed. And it's because there's other things that can imitate or mask leg pain that's related to circulation. What you're describing is more of what we call, well, let's just take a step back. Claudication is walking pain, and that's the typical pain associated with PAD in the lower extremities, and it's in the muscles usually. And so there's different types of claudication. In this case, when we talk about circulation claudication, we call that vascular claudication or vascular walking pain. But also there are other components or other reasons that neurogenic claudication, in other words, nerve pain when you walk, is very it can overshadow or confuse a picture of PAD. And what you're describing, just a typical teaching when it comes to nerve pain, it's a positional pain. The nerves that come from the brain, they run through the spinal cord, especially in the lower back. Over the years with motor vehicle accidents, repetitive injuries, those nerves become inflamed. The spinal column becomes inflamed and it pinches those nerves, and that can cause pain in the legs. That's usually a positional pain. You're laying down for a good amount of time. You're sitting down in one position for a good amount of time, or you're standing for a good amount of time and you get pain that kind of runs from the course of the back all the way down the legs. That's more consistent with nerve pain. The typical traditional pain associated with circulation is a walking pain. Um, However, in the setting of having hardened arteries and atherosclerosis, a very simple test to get that you can ask your doctor or your specialist, whoever treats you for this or you're comfortable with, is what's called an ankle brachial index, ABI for short. What that does, you check the blood pressures on the arms, you check the blood pressures by the ankles. That difference there gives us a specific number, and that tells us if you have any degree of peripheral arterial disease or circulation problems. It sounds to me like this is more of a neurogenic, classically neurogenic sort of thing. And again, I'm not, I'm not giving you any medical advice here over
right.
the line. But from what the story is, it sounds like it's more a neurogenic type of pain. But given the risk factors of atherosclerosis, in this case, what I would do as a provider, theoretically or hypothetically, would be to order this ABI test. It's a very simple test. It's cheap, it's quick, and it gives us a lot of information if it's related to the legs. But it just sounds like that's more of a nerve type of issue. If I were to kind of, again, hypothetically say that's probably what I would be thinking.
Okay, doctor. Now I know they
Mm-hmm.
said it was severe um
Mm-hmm.
atherosclerosis of the aorta.
Mm-hmm.
And
Yeah.
and I don't know why, because I've never smoked. I'm not overweight.
Mm-hmm.
I try to watch what I eat and things like that. So I don't know why that, really happened.
Yeah.
So, seeing
So.
as they said severe, that kind of scared me. And the fact that my legs do that at night or when I'm just sitting,
Mm-hmm.
it's very, very painful. But I do know of that test you're talking about. I did read about that,
Mm-hmm.
the ABI. Um,
Mm-hmm.
um, and I'd like to get one of those done. So I'll have to figure out. I don't have very good luck here with the doctors. I mean, I just feel like
Mm-hmm.
they really don't. I mean, you just explained to me more than my doctors have in the past year. I did suffer. I was in a very bad auto accident about 8 years
Mm-hmm.
ago, and I did break both of my feet. Both
Mm-hmm.
feet were broken. And ever since then, I've felt that problem when I laid down and when I'm sitting. So perhaps it was nerve damage in my back from the accident. I really don't know, but I
Yeah,
appreciate
that's
your,
yeah. I think one of the things, and I'm kind of smiling as you're telling me this because I get this a lot also. And unfortunately, as physicians, we're very guilty about doing this, is we don't take the time to kind of sit down and talk about things the way we're supposed to in detail, and in a way that our patients can understand. We have a tendency to speak doctorese or a tendency not to explain anything at all. One of the things that we run into a lot of physicians is we become so overwhelmed with all the imaging, the tests, the patients, that even things that may be normalish or maybe benign, we don't get back to the patient. A lot of times, no news is good news, but no news is also, it can be alarming news for the patient if they don't know. And so sometimes, then on the other end, sometimes we have to push our providers also to kind of do things, especially in the setting where people, our patients are feeling bad. And we have an idea what's going on. I think it's never a bad idea to sit down and talk with your doctor about this, whether it be a primary doctor, a vascular specialist, cardiologist. And it's a very simple conversation. Hey, listen, I'm having back pain. Sounds like it's some type of claudication. I have risk factors. What do you think about an ABI? The physician, when you throw it
okay.
out there like that, it's kind of like, oh, well, you know what? ABI might not be a bad idea, rather than saying, hey, listen, I talked to this guy and this, and I did my Google doctor search and I need
Yeah,
an ABI,
right.
right? So it's different. So I think it's totally reasonable to get that done with the physician. Um, Now the atherosclerotic part to this. So whenever it comes to atherosclerosis and hardening of the arteries, and this is circulation in any part of the body. So there's three main areas of circulation. You have the coronary cardiac circulation, the heart. You have the peripheral, which is outside, and usually the aorta all the way down to the toes, and then you have upstairs the neurologic circulation. So strokes up here, heart attacks here, and then leg pains and more acute issues down here. But it's all a continuum of the same process, hardening of the arteries. Now, the risk factors for having hardening of the arteries, there's two main groups that categorize this into. Number one, things you can change or control. Number two, things you can't change or control. You can't change or control genetics, age, gender, or I'm sorry, male or female, whatever you're born with, are born in. Those things you can't change. A female
Right.
over the age of 65 or a male over the age of 55 automatically has an increased risk of having hardening of the arteries and even heart disease and peripheral vascular disease. So you can't change that. And you can't change age. If you have a first degree relative who's had a heart attack, again, male younger than 55 or female younger than 65, or circulatory problems like that in the legs, you're at automatic risk. So these are things you can change. That's one group. Things you can change are what we call the modifiable risk factors, the risk factors we can change. High blood pressure, high cholesterol, sugar diabetes, smoking cessation, unhealthy lifestyle, sedentary lifestyle, and poor diet and obesity. These are all things we can control and change. So in the range of things, and what I just mentioned, you can probably kind of think about what your risk factors are, whether that's things you can change or things you can't change. And if you can change them, those are things you can address that are going to help you out long term to reduce progression of that hardening of the arteries. Again, just because you have hardening of the arteries doesn't necessarily mean you have blockages. And this is a good time to kind of sit down with your either your primary doctor or your specialist to go over which risk factors apply to you and how they can help you out with that.